The broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone, and thank you for joining our continuing education webinar tonight. We'll be talking about prescription opioid abuse and dependence in New Jersey with Morgan Thompson. I'm Helen French, Development and Education Director at NASW New Jersey, and I'll be moderating the webinar tonight. A few housekeeping items. If you are having any difficulties with the online or audio portion of this webinar, please make sure you have entered in your audio PIN and your computer speakers are on. Due to the number of people registered and to protect your confidentiality, attendees' phone lines will be muted. You can type questions in the GoToWebinar chat feature, which is on right of the screen, and we will stop at various intervals to answer any questions about the material. We'll also take questions at the end of the presentation. At the very end of the webinar, I will put up the link for the post-test quiz in the chat box, so you can take it tonight if you like, and an email will also be sent to you within 1 hour of the webinar concluding. We are recording this session, so please keep that in mind when you are asking questions. Now I'd like to turn it over to Morgan Thompson.
Thank you so much, Helen. Good evening, everyone. Again, my name is Morgan Thompson. I am a social worker, Master of Social Work from Rutgers University. I'm the CEO of Prevention Links. We're a nonprofit based in Union County, Roselle, focused on substance misuse prevention and recovery support services. And so tonight we're talking about prescription opioid abuse and dependence in New Jersey. Just to give you a little overview of what we're going to be talking about, and I just want to kind of qualify by saying that prescription opioid misuse is just one piece of the opioid epidemic, and the opioid epidemic is really just one piece of the addiction crisis that our country is facing. But prescription opioids have impacted our society in really unique ways, and ways that we as social workers need to be aware of. So we're going to discuss the statistics, the trends, how prescription opioid misuse has increased over the years, what it has cost us, not just in terms of financial costs, but the very real cost in terms of lives lost due to prescription overdose deaths. We're going to look at the national trends, also at the statewide trends here in New Jersey, and then take a look at the breakdown by county. We're going to talk as well about treatment of prescription opioid use disorders, including the various forms of medication-assisted treatment, the ASAM levels of care for substance use disorder treatment, that's American Society of Addiction Medicine. And then we're going to kind of put our macro social worker hats on and talk about some of the environmental strategies and policies that have really been designed to prevent and reduce prescription opioid misuse on a more, a larger scale. So educational interventions, referral initiatives, and information about overdose reversal. And then finally, we'll conclude with some of the key resources and initiatives that social workers should be aware of to assist the individuals, families, and communities you work with. And I just really want to emphasize that everyone has a part to play, even if this isn't necessarily an area of emphasis in your practice. It affects everyone. Everyone knows someone. So it's very important to approach this topic with an open and creative mind. So when we look at some of the major threats to health and safety that have faced Americans, rates of overdose death surpasses many of them. So nationally, there were 64,070 overdose deaths in 2016, and that number has grown since then, and we'll take a look at that. But this was a particularly important year because it was the first year that overdose deaths surpassed car accidents in the height of their highest point of leading to accidental death. So you'll see these different health crises that we've faced, and some of them not necessarily health crises, but threats to life that we've faced as a nation. So one to point out that's particularly interesting, so you'll see at the bottom there, 1968 was the deadliest year of the Vietnam War for our country. We lost 16,899 Americans in 1 year in that conflict. Now, that's an interesting number because over the entire course of the Vietnam War, which was 19 years, there were 58,220 deaths total of Americans. And so even throughout the entire course of the Vietnam War, we didn't lose as many people as we did in 2016 to opioid overdoses, which is pretty profound. So we're going to talk a little bit about how the opioid and prescription opioid crisis has evolved. So in 1995, the FDA approved OxyContin for prescription use. So the active ingredient in OxyContin is oxycodone. And during this time, there was a real push in the US medical community, realizing that patients who were in pain were inadequately treated for their pain, which is legitimate and is still an issue. And some of the efforts to curb the opioid epidemic have actually made it harder for individuals who legitimately need prescriptions to manage their pain to access them on a consistent basis. So kind of going back, what we saw in 1996, the American Pain Society pushed for and successfully pushed for the adoption of a fifth vital sign, that being pain. And so providers would routinely assess and respond to pain in the same way that they do blood pressure, heart rate, respiratory rate, and temperature. And so the manufacturer of OxyContin, Purdue Pharma, capitalized on this with a very aggressive marketing campaign around OxyContin, taking ads out in medical journals, hosting conferences, and shortly thereafter, in the early 2000s, we started to see prescription opioid-related overdoses and treatment admissions start to increase. So, you might be hearing some things in the news that states are actually bringing lawsuits against Purdue Pharma and now some other pharmaceutical companies for misrepresentation of the risks of OxyContin and other opioid painkillers. So just this year, there was a $270 million settlement with the state of Oklahoma related to OxyContin. And so that's kind of where we started. And obviously, addiction is nothing new. It's been going on, as, far back as we can remember, right, in our collective history as people. But this particular wave started with prescription pills, and then for a number of reasons that we'll talk about later, folks either could not access the prescription pills that they were now addicted to, or they knew they could obtain them cheaper by purchasing heroin, which is a chemically similar, street drug that can be bought at a much cheaper price, more readily available, less restrictions. So we started to see a lot more people using heroin who had previously been using prescription drugs. So we started to see faces of heroin addiction that were not necessarily what we would maybe think of when we think about someone who is a heroin user. I think that's a little bit of a, misnomer, because really, anybody, addiction doesn't really discriminate. Anybody can use any drug at any time. And so that's kind of a public perception, but we did definitely see a trend with younger people in particular, and even with some older adults who were prescribed opioids and then moved on to use heroin. And so then the third phase of the crisis made a return to prescription opioids. However, the particular prescription opioid was fentanyl, which is a highly potent form of morphine of oxycodone that can be used in the treatment of very severe chronic pain where other forms of opioids are no longer effective. And so fentanyl was not being diverted. It was that we were seeing fentanyl coming into the country illicitly and, being cut into street drugs like heroin. And so we saw a real large spike in overdose deaths in 2016, and a great majority of those deaths were related to fentanyl, more than we had seen before. And even further than that, we're now seeing fake prescription pills that are fentanyl being pressed into pill form to look like, in some cases, opioids, but in other cases, even non-opioid prescription pills like Xanax. And so these are just some of the trends that were observed by like the Drug Monitoring Initiative and the DEA over the last, 2 decades. So fentanyl, 2 milligrams of fentanyl can sedate a 2,000-pound elephant. Carfentanil, we'll talk about, it's even stronger. So we saw a lot of headlines right around this time, 2016, as the overdose deaths started to increase. What you'll see here is a deadly dose of heroin to the left and a deadly dose of fentanyl to the right. And in that little circle is a deadly dose of carfentanil. So just to kind of give you some background, fentanyl is chemically similar to morphine, but it's 50 to 100 times more potent. Like I said, it's used to treat patients with severe pain that really can't be managed with, oxycodone and other opioids. Dealers will put, illicit drug dealers will put a stamp on the bag that they, package the heroin in. And so from that, we can track certain batches of drugs. And so by those stamps, the New Jersey Drug Monitoring Initiative was able to track how many of those drugs that were seized had fentanyl or carfentanil in them. And they were also able to, through the medical examiner's office, start to track how many opioid-related deaths involve fentanyl. So in 2010, only 14.3% of opioid-related deaths involved fentanyl, and by 2017, that number rose to 59%. At first, people thought that overdoses involving fentanyl couldn't be reversed with naloxone. That's the overdose reversal drug. This isn't actually the case. It's just that it requires multiple doses of the naloxone to revive someone from a fentanyl-related overdose. And we're going to take a quick stop if anyone has any questions so far.
Hi, Mom.
Did we have any questions?
Yeah, a question. Do you see an increase in doctors who are unwilling to prescribe these meds to patients who have severe pain because they're worried about professional backlash? I have had cancer patients that have been affected by this.
Yes, I mean, I haven't really seen any studies about it, but I know anecdotally, folks have been having those challenges, and there's limitations placed on how often a prescription could be renewed. Doctors may be less inclined to prescribe because of exactly what you said. Many doctors went to jail or lost their licenses because of illicit prescribing of these drugs, and so it's a real challenge, and it's creating a lot of issues for folks who are legitimately ill and in pain. So you're right on the money with that. It is a challenge that I think the powers that be are trying to address.
And we have a clarifying question. Did you say fentanyl was a stronger form of oxycodone or morphine?
It's chemically similar to both, but it's much more concentrated, and it's manufactured. It's its own compound. It's not naturally occurring.
Thank you. Okay.
Anything else?
No, I think we can pop along.
Okay, great. So just talking a little bit about the economic costs of the opioid crisis. So in 2015, the Council of Economic Advisors estimated the cost to be $504 billion. So looking at healthcare costs, criminal justice, lost productivity, both due to folks who are unable to participate in work and other activities because of their use and who have passed from an overdose death. So, previously, studies only really looked at the impact financially of prescription opioids and not the heroin or illicit opioids. So this study was one that, really casted a wider net. And then the National Center for Injury and Prevention estimated $78.5 billion annually for treatment. And you can see that the amount being paid towards treatment has risen. However, in a couple of slides, you'll see that prescription opioid use has actually fallen. So the reason being kind of what I described before, even though we have these controls in place that are curbing the illicit prescribing, we are still seeing folks dying of overdose deaths, and we're seeing treatment costs go up because they're either using other substances like heroin or opioids, or they're continuing to find a way to get their opioid drugs. So that's why we see that disparity. A lot of these folks are now using illicit opioids. So even if, even with the environmental strategies that have been put in place, we're still going to be seeing the impact of this crisis and of the effects of prescription misprescribing for a very long time. This gives you a breakdown of the costs by year and type. So you can see those numbers are increasing. They're projecting that it'll exceed $200 billion after 2020. And so here you'll see the national overdose deaths specifically from prescription opioids. And by 2014, it was nearing 20,000. Whereas heroin, it took a lot longer for the heroin death spike, which is interesting because I think during that time, that kind of 2012 to 2014 period, folks thought that heroin was the cause for a lot of these overdose deaths and was the real danger because I guess we want to believe that FDA-approved medications are safe, but at the same time, if taken in the wrong dosage, they're deadly. And so, we were seeing a significant number, even more than heroin overdose deaths caused by prescription opioids prior to 2015. 80% of heroin users report that they started with prescription drugs. That it was very common before these the measures were put in place to kind of monitor opioid prescribing and holding doctors accountable for individuals to go to multiple doctors to obtain multiple prescriptions for the same drug, things like that. So even if a doctor was not intentionally prescribing opioids in a nefarious way, folks were still finding ways to, get excessive amounts of these substances to be able to abuse them. So then we saw in 2015, the synthetic opioids started to creep up. And then by 2018, it had reached over 30,000 for fentanyl-related opioid deaths, while heroin and painkillers were stabilizing on a slight decline maybe, but we still overall saw deaths rise because of fentanyl and have continued to into 2019. So this is just another way to kind of see the differences in the potency, the nice visual understanding of how much more potent carfentanil and fentanyl are than heroin and morphine. So it's also interesting to point out that this is a pretty uniquely American problem. So this graph is adjusted for population, and US overdose deaths are nearly double that of the next highest country, which is Sweden, for overdose deaths. Now here in New Jersey, we'll see that so this is from 2016. You'll see that highlighted area is the 25 to 35-year-old age range, where you'll hear a lot of news stories and studies about how young people are disproportionately impacted by overdose deaths. Partially, as social workers, we tend to learn a little bit about the brain and how it works, and I think this has just become common knowledge that the adolescent brain is still developing. So if young people are experimenting with substances while their brain is still developing, they're much more vulnerable to develop an addictive disorder later in life. And so that may be part of what we're seeing as well. And then something else to take note of is that in the 45 to 55-year-old age range, we also see a bit of a spike. And this is different than what we see nationally. So that same year, again, you'll see that there's that same spike in the 25 to 34-year-old age range, but not in the 45 to 54-year-olds. And we don't really know why that is. Just a conjecture, it's possible that being so close to major cities and to the ports of Newark and Elizabeth, and there's New York City, Philadelphia, this has always been a high drug trafficking area. There has been high rates of heroin use for a long time. And so folks who maybe have been managing their heroin use for decades are not aware that they're now, having fentanyl introduced into their drugs. And so that can cause an overdose in someone who, has never had one before or hasn't in years, because they're not aware of the potency of the drug. And so you can see in New Jersey that we saw a similar trajectory as we did nationally. It just kind of continued to climb. And then we saw that spike in 2016 related to the fentanyl deaths. The 2018 data is still being confirmed, but we continue to see significant climbs in overdose-related deaths over the last several years. In talking about which counties are most impacted, there's really no county that isn't impacted at this point, but certainly it's more intense in certain places. So you'll see Essex County is the one that in the Northeast that's particularly dark, having more than 100 deaths, and then Camden County in the Southwest. But also Passaic, Middlesex, Mercer, Atlantic, are all very highly impacted, and it keeps changing. I mean, Essex and Camden are typically toward the top of the list for the most deaths, but it's always changing the rates from county to county. And so this is just another graphic depiction of the same information. So talking a little bit about environmental strategies and how they're making a difference in New Jersey. Education is key. So, this study is from a while ago, but again, that was really when the prescription opioid crisis started to take off, and most people who were abusing prescription painkillers were obtaining them for free from a friend or relative. So it's not even that many were getting them from a doctor, or even multiple doctors, or on the street or from a drug dealer. There was so little information at that time, and again, this is from 2010. People were so misinformed about these drugs at that time that parents would give an opioid to their child, not really understanding the risks. Because again, I think that question spot is in the wrong place. I apologize. Not really understanding the risks associated. Helen, I'm just going to skip through this question page because it's in the wrong spot. I'm sorry about that.
Well, we do have one question, Morgan, if you don't mind.
Okay.
Yeah.
Sure.
Do you think that the free Naloxone was a double-edged sword, that it gave abusers the ability to overdose and still survive?
I do not believe that. I believe that people can't recover if they're dead. And it's a health condition, and naloxone is there to save lives. I really don't see a downside to it. Any other questions?
No, please go ahead.
Okay. So 1 in 5 parents indicate that they've given their teen a prescription that was not prescribed for them. So that might, I think now we're more educated and we know that the dangers associated with that, but you can also imagine, scenarios where, okay, well, I'm going to take my child for a dental surgery and they're going to get, or they have a toothache, and I know that the doctor is going to prescribe X and I have that left over from my last dental surgery. What's the big deal? But that is very dangerous. That's really taking, years and years of medical expertise into our own hands. And, obviously that's dangerous and not appropriate. So we've really done a lot in the prevention field to educate parents about the importance of only allowing, their children to get medications prescribed by a doctor, but also to lock up their medications at home, dispose of unused medications, because, while it may seem, as I said, very innocent, it has some very detrimental effects in the long run. 1 in 5 adults reports that they've abused a prescription, so taken a prescription that was not right for them. So if you remember back on our graph, those 25 to 35-year-olds who were overdosing and dying, this is where it starts. It starts with experimentation, with very, very potent prescription drugs many times. So why did we start to see a decrease in prescription opioid use overall and in prescription overdose-related deaths slightly? So one big change was the prescription monitoring program. So it's a database that launched in 2012. It collects data on all controlled dangerous substances that are dispensed to New Jersey residents. Prescribers are required to use it. Pharmacies are required to use it. And they can track whether their patients are getting medications from other doctors before prescribing to them. So some early limitations was that not all the appropriate prescribers were linked in, dentists, mental health professionals. I believe veterinarians are not yet part of the prescription monitoring program, but it's something that is being considered because the medications that are prescribed for pets can oftentimes be human grade. And another issue is that, for our neighboring states, if folks are getting prescriptions from New York, Pennsylvania, that might not get caught on the PMP. So we've now linked the New Jersey PMP to New York and Pennsylvania. That program is looking to be expanded. The Murphy administration has been looking at ways to really ramp up that system and make it more effective, looking to get a doctor to review the data and flag suspicious activity, things like that. So this has been really key and a model that's been used throughout the nation to curb overprescribing. So then in 2016, the Centers for Disease Control released their pain guidelines for prescribers. Very simple things. Don't use opioids first, try other methods. I know for myself, I go to the doctor, and often the first recommendation is still, oh, well, we'll give you Vicodin, or we'll give you, whatever it may be, when it can be easily managed with aspirin and ice. Not always, certainly, as someone else brought up. There's a need for prescription opioids, and there's situations where they're indicated. It's just being mindful of the risks and considering whether or not there's other options to explore first. Being, upfront with the patient about the fact that being 100% pain-free is not a realistic expectation. Often if somebody, takes opioids when they are in legitimate pain, they may experience pain later on. It's called a rebound effect. It's also very important that prescribers communicate the risks associated with opioids. In one state, it's escaping me which one in particular, but for every opioid that is dispensed, they accompany it with an naloxone kit, which obviously has practical implications, but it also sends a message about the dangers associated with those medications. As I said before, another really key piece of getting the prescription diversion under control has been Project Medicine Drop. So at various locations around the state, mostly police stations, there will be what looks like a mailbox where people can bring their unused medications to dispose of them, not just opioids, really any. It's monitored 24/7 by law enforcement. And so in addition to just having those available, there's different campaigns that take place to encourage folks to actually use the medication drop boxes. There are some obvious ones like pharmacies, doctors' offices, where we can give information about the drop box locations, but also, like I said, vets' offices, the veterinarian, funeral homes. If a loved one has just passed and they were ill, they may have a lot of medications in their home, and so that's the last thing on the family's mind is to dispose of those medications, but it's something that we really want to remind them to do, and just constantly reminding parents of the importance of securing their medical cabinets. And then there's a lot of education that needs to be done, both for individuals, communities, professionals, for families who have a loved one who's struggling with opioids or any type of addictive disorder. There's a model called CRAFT, which stands for Community Reinforcement and Family Training. And this is very different than I think the typical messaging that's sent to loved ones who have someone with an addiction in their life. Oftentimes we hear, that any type of communication is enabling the addiction, that the only way to help them is to completely cut them off. The CRAFT model is really an approach that is evidence-based. It was created by Dr. Bob Myers, and it has a lot of research to back up its efficacy, and it's designed to empower families with concrete skills and strategies to improve their communication with their loved one and to reinforce behaviors that guide them towards seeking help in some form or fashion. And so the CRAFT model is starting to kind of be adopted as a best practice, as something that families who have a loved one who is using opioids should be aware of. And so the state has launched 3 regional family support centers. And so, there's a northern representative in Bergen County, but they'll travel throughout the county to provide workshops about the CRAFT model directly to family members. In the central region, it's based out of our office here in Union County, and then down in Camden County, covering the southern region. And so that's the regional family support centers, and those services are all free. In terms of professional education, we do have a pretty limited workforce that is equipped to assist folks who are struggling with an addictive disorder. The CPRS is the Certified Peer Recovery Specialist. So this is someone who has their own lived experience of addiction and recovery. They're in stable recovery themselves. They've, walked the path, and they're trained to use their lived experience in a very purposeful way in order to assist someone who is new in recovery to transition into stable recovery, or to help someone who is using to initiate recovery. So that's a peer-based role. Then we have the CADC, Certified Alcohol and Drug Counselor. And so this is a certificate program and a credential that folks can get specific to treating addictions. It's a bachelor's level, or I think you may not even need a bachelor's. I'm not 100% sure, but there is training available at many colleges, including community colleges around the state, and it's also offered by a number of agencies. There's a test and a practicum involved, and if you already have, say, an MSW and you obtain your CADC, you're eligible for the LCADC, which is the Licensed Clinical Alcohol and Drug Counselor. So we definitely need more LCADCs if this is of interest to you, and CADCs and CPRS. If this is a field that interests you, certainly it's in pretty high demand at this time. And then just continuing to educate our medical providers. There have been some improvements in the education requirements for doctors around safe prescribing and pain management. But we also need more doctors who are specializing in addiction science. We also need doctors who have obtained the buprenorphine waiver so that they're able to, prescribe. It's more commonly known as Suboxone. There are other brand names, but this is a medication that assists with cravings, withdrawal management, that can be prescribed for folks, and we're going to talk about it a bit more later. But a real barrier for folks to access this form of treatment is that there just aren't many doctors who have the waiver to prescribe it. So we talked a little bit about naloxone before. In May of 2013, the Overdose Prevention Act was signed into law by Governor Christie. And so at this point, as of this year, we would say that naloxone is in the hands of about 90% of law enforcement officers in New Jersey. So if you think about what the overdose rates are currently, they would be a whole lot higher if it weren't for the Overdose Prevention Act, which not only allowed for naloxone to be obtained by lay people, but it also allowed for immunity in the event that somebody who was using drugs maybe somebody is using drugs with a friend, the friend overdoses and calls 911, there won't be any legal repercussions related to personal use if you're calling, in good faith to save someone's life. So that was a really important piece of legislation. We still need to get naloxone into more people's hands. There's still plenty of deaths that are not being prevented because the person is not in the right place at the right time to be near someone who can administer the naloxone. So there is a need for expanded access and use. There are trainings available throughout the state on a pretty regular basis where they do give you, in addition to the education about how to use naloxone, how to identify an overdose, they also give you a kit to take home with you in many cases. Another great resource for learning about, community level data around the opioid crisis is NJ Cares. So this is through the Office of the Attorney General here in New Jersey. And so they keep track county by county of the number of overdose deaths, the number of naloxone administrations, and the number of opioids being prescribed in each county. Okay, I'm gonna pause again.
Yes, we have a couple of questions and also some clarification. Somebody asked that you repeat what CPRS stands for, please.
Sure, that's Certified Peer Recovery Specialist.
Okay. And then also somebody asked why the decrease in prescriptions. You mentioned something about that a couple of slides ago.
Right, so there's fewer opioids being prescribed overall because in response to some of the, how can we say, really fraudulent prescribing that was happening with, a handful, not many, but a number of doctors were capitalizing on the popularity of these drugs and prescribing opioids when they shouldn't have. And these were referred to as pill mills. And so the DEA got involved, and many of these places were shut down. Doctors were prosecuted, lost their their ability to practice medicine. And so I think that scared a lot of doctors to be a lot more vigilant in their prescribing practices. And also with the PMP, for doctors who, unbeknownst to them, were prescribing to someone who had already gotten a medication from another doctor. Once the PMP came into play, they were able to check and see, oh, well, Dr. A prescribed oxycodone to this person 2 weeks ago, and here she is in my office, trying to get the same prescription when she shouldn't have run out by now anyway. I'm going to go ahead and not prescribe this unless I've consulted with Dr. A first. And so that naturally led to a decrease in the amount of opioids that were being prescribed. Hopefully most of them, that were not needed to be prescribed, that were being prescribed for, misuse. But I'm sure in some cases it has created challenges for individuals who legitimately need the medications to obtain them. So again, it's a challenge that we're facing.
One of our audience members said, I was told that the PMP is being extended to psychotherapists. Is this something that you could speak to?
I heard that too. I'm not sure if it's happened yet, but my understanding is that mental health professionals would have access to the PMP soon if they do not already.
And then somebody asked if you know of any efforts for the PMP to be nationalised. Is there a great push for that?
I do. I don't recall the name of the organization, but I attended the Prescription Opioid Summit in Atlanta, Georgia 2 years ago, and there was a group that was speaking about just that. It would be very helpful because there are these, obviously the ability to obtain opioids from different states. People can order them over the internet in some cases. So, that would be very helpful, and it would be great for data collection purposes and monitoring trends. But I know there are a lot of just logistical barriers to making that happen. So unfortunately, I don't have the specific name of the group that's leading the charge on that effort, but it does seem to be in the works.
Okay, and one last question. Do you know how we would access the PMP?
So I don't know, but my understanding is that if you're a qualified user, like if you're a medical doctor, a dentist, a prescriber of these medications, a pharmacist, through your licensure, you would, I believe, obtain some type of, access or login credentials. So I would assume that as it rolls out for mental health professionals, it will be similar in that it'll be for licensed mental health professionals, and somehow through your licensure, you'll be notified. I think that would be my guess, but I can't really speak to the actual process.
Thank you, Morgan.
No problem. Okay. So I've mentioned a few times medication-assisted treatment, also known as medication-assisted recovery. So that's the use of FDA-approved medications in the treatment of an opioid use disorder. And so that's typically in combination with therapy and other types of support. None of these medications work in a vacuum. They're most effective in combination with groups, individual therapy, peer support, self-help, drug testing, and other types of support and accountability. Something that's particularly challenging is that the 12-step community has been leaned on heavily to support individuals with substance use disorders. So Alcoholics Anonymous, Narcotics Anonymous, these type of programs And there's a lot of challenges in those communities with accepting folks who are on medication-assisted treatment. They're certainly welcome at the meetings, but they often face some stigma from other people in recovery who feel that the use of these medications is not legitimate abstinence. However, when they're appropriately prescribed and when they're taken as prescribed, someone can really, make significant gains in all areas of functioning and really thrive in their recovery process. So it's another area of education, but also an area where we have to build up other types of supports that are designed to be accepting of folks who are on medication-assisted treatment. So the three main forms of MAT, and these all work differently, are methadone, buprenorphine, and naltrexone, particularly the extended release form. So methadone has been used for decades. It has to be dispensed by a certified opioid treatment program. It's an opioid agonist, which means it activates the opioid receptors in the brain, and it can be abused if it's taken more than prescribed. But it does work very well in relieving the painful symptoms of opioid withdrawal. Buprenorphine is an oral tablet or film, which is prescribed by a doctor in an office-based setting. It's a partial opioid agonist, so the drug, like methadone, binds to the opioid receptors in the brain and activates them, but not to the same degree as a full agonist like methadone. So again, the most popular or well-known brand name for buprenorphine would be Suboxone. And then we have the extended release naltrexone. This is a monthly injection, and it's an opioid antagonist. So it binds to the opioid receptors. I'm sorry, I think I misspoke before. So the buprenorphine, the agonist, it activates the receptor, whereas the naltrexone as an antagonist kind of blocks the receptor so other opioids can't enter it, so that there's no actual effects that are exerted. So there's really no abuse potential because it's not activating the opioid receptor. So that the common brand name for naltrexone extended release is Vivitrol. Just something to note, although someone who has, been taking naltrexone can't really achieve, a euphoric effect from opioids, other types of drugs will, have effects, whether it's, stimulants or marijuana or benzodiazepines. So it's just specific to opioids. So all of these medications have advantages and disadvantages. Certainly, the abuse potential of methadone and buprenorphine is a challenge. Naltrexone, unfortunately, someone needs to be abstinent for 7 days before, maybe not 7 days, for at least a few days, because if they're not, when they introduce the drug, they might become ill. So it can be difficult for folks to stay abstinent long enough to be able to initiate the naltrexone. It's also important to note that someone who is on methadone or buprenorphine, if they are using alcohol or benzodiazepines, because they're central nervous system depressants, they're actually at higher risk of an overdose death. So this is just one study that was done comparing the effects of folks who were staying abstinent, who were taking a medication, and who were not. And so you'll see the different medications listed. You'll see the percentage who remained abstinent, who were taking the drug as prescribed. And then in the right column, the drug-free or placebo column, these were folks who were either not taking any medication to aid in their recovery or who were taking a placebo. And you'll see that there's a pretty significant, significantly higher rate of abstinence among the groups who were prescribed and adhering to a medication-assisted treatment regimen as opposed to those who were drug-free or placebo. So there is some good evidence to support the use of these medications. It's a really big push right now. A lot of the efforts coming out from the federal government are focused on increasing access to MAT. So there's a lot of work being done in that regard, but as I mentioned, there's still a lot of challenges around having adequate prescribers. So in the interest of time, I'm not really going to go too in-depth into the different levels of care. I just want you to know, as you're working with folks, the things you want to be aware of. You want to make sure that if you're making a referral to addiction treatment program of any kind, whether it's inpatient, outpatient, withdrawal management, whatever it may be, that it's a reputable program. So you want to make sure that you just want to get a sense of what is the clinical licensure of the staff that's going to be working with the individual, what is the staff to client ratio, how is their, how does they involve families in the treatment process, and what does their aftercare planning look like. So, you really want to make sure that the program is reputable before you make a referral. Also important to be wary of interventionists and peer recovery specialists or coaches who aren't really tied to an agency. Often, these folks are representing themselves as recovery coaches or interventionists, but they're actually, trying to kind of find people who have good insurance and getting a kickback from the treatment program, even if it's not the right placement for that person. So again, be mindful of that. There are lots of interventionists and recovery specialists and recovery coaches who are legitimate, who do very good work. But again, you just want to kind of get a sense of, are they tied to a reputable agency? Another big and often overlooked piece of the continuum of care for substance use disorders is recovery support. So these are non-clinical services. They're designed to transition individuals from early recovery to stable recovery. So I talked a little bit about some of these in the beginning. These are things like recovery community centers, recovery high schools, collegiate recovery programs, supportive housing for people in recovery, supported employment. And these type of supports really increase access to treatment, to social supports, to housing stability, and lead to decreases in substance use overall, decreases in relapse, decreases in criminal justice involvement. And so, again, there are many places that are reputable that providing these services that are very effective and take a long-term approach. So treatment typically lasts maybe, anywhere from a couple of days to maybe, a year and a half is some of the longest programs I've heard of. But on average, I'd say 3 to 6 months is, how long most people stay in a true treatment program. A withdrawal management or detox program is more like a 3 to 10 day process. And so these are really important, as I said before, because not everybody responds to a 12-step program like Alcoholics Anonymous. Many do, but also some don't. Some don't feel accepted or comfortable. So we want to make sure other types of supports are available. And then just some programs that I want to make sure you're aware of in your communities. So we have the ORP program, that stands for Opioid Overdose Recovery Program. And this is where when an individual is revived with naloxone after an overdose and they're transported to the hospital, a peer recovery specialist meets with them bedside and will work with them to connect them to treatment if that's something that they are open to. PARI, similar police-assisted addiction recovery initiative programs. So when folks are arrested, they're given the opportunity to go to treatment and to meet with a recovery specialist, but also just kind of those 4 dimensions of health: home, purpose, community, that are outlined by the Substance Abuse and Mental Health Services Administration are all really key in ensuring that folks have an opportunity to achieve long-term recovery. So, GED, vocational training, working on resumes, housing, these are all components of a recovery-oriented system of care for substance use disorders. So to summarize, 2017 we had 72,000 deaths. That number grew from 35,000 in 2011. There are at least 3 million people currently addicted. There are some good policies in place that have started to curb some of the issues, but we need many more. There's no magic bullet, and we need to keep trying new things and really starting to measure in a more meaningful way, how successful these programs are, which is something that the state is very invested in doing in the coming months. So I would really encourage you to get trained in naloxone, be aware of the various phone lines that are available to get people connected to treatment and to get support. We need people who have expertise in these areas, so CADC, CPRS are great options. Social workers continue to seek out training on these topics. This is a really, really high-level overview. This training could be several days to really get into the finer points of all the pertinent details. And don't be afraid to ask the folks that you're working with about their drug use, including prescription drug abuse. They may misrepresent their use. It may take several weeks or months for them to be honest about it. It's normal because of this shame and stigma associated with drug use for folks to lie about that. And be aware of what the resources are in your county. I'm going to give you my contact information if you need any assistance finding a particular resource, whether it's treatment, recovery support, prevention. I'm more than happy to be of assistance to you in that way. So I think we have a couple more minutes if we have any questions. I'm just going to put my contact information up so you have it.
One of our audience members, referring back to the PMP question, said, I'm a prescriber with another license. We're notified by email to sign in and complete information. Also, your sign-in information must be updated at regular intervals, and prescribers are sent emails for that as well. So that's what one person has to say about the PMP.
Wonderful, wonderful point of clarification. Thank you.